Catastrophic antiphospholipid syndrome in a patient with diffuse large B-cell lymphoma in remission by Amber Morales and Junain Hernandez. Catastrophic antiphospholipid syndrome, most likely known as CAPS, is a severe manifestation of antiphospholipid antibodies affecting 1% of patients with antiphospholipid syndrome, APS. The condition is frequently fatal if not recognized and treated early. The association of malignancies such as lymphoma and CAPS have been observed. The patient is a 57-year-old female with past medical history of lupus, rheumatoid arthritis, lymphoma in remission, and peripheral artery disease (PAD), who presented to the emergency department with worsening general malaise along with bilateral lower extremity pain associated with numbness and weakness. Upon examination, findings of purple discoloration in the feet, decreased pulses of the dorsalis pedis, and posterior tibial on the left leg were noted. Afterwards, lab results show coagulopathy with worsening thrombocytopenia and anemia concerning for disseminated intravascular coagulation. The patient developed an extensive thrombosis despite having supratherapeutic INR of 7.32 and a negative heparin-induced thrombocytopenia HIT antibody test. The patient was transferred to the intensive care unit, ICU, for a higher level of care. Subsequently, an arterial study revealed a severe arterial insufficiency at the aortoiliac bilaterally. Bilateral ankle and toe brachial indices at the time suggested severe arterial insufficiency and microcirculation disease. In addition, a CT angiography of the abdomen, pelvis, and lower extremities revealed moderate to severe aortoiliac atherosclerosis and occlusion of the right superficial femoral artery, left superficial femoral artery, and right popliteal artery. In addition, a photoplethysmogram showed all toes blood flow was severely diminished, and findings were compatible with a venous thrombosis involving bilateral common iliac veins, external iliac veins, and the inferior vena cava to the level of the renal veins. Vascular surgery was consulted and percutaneous thrombectomy and thrombolysis were recommended but not feasible immediately due to severe thrombocytopenia of 36,000. 2 days later, she underwent a percutaneous thrombectomy of multiple lower extremities along with inferior vena cava, IVC, and right superficial femoral artery lysis catheter placement. After several days of hospitalization in ICU, anticoagulation, IVIG, and corticosteroids, her symptoms improved. Early intervention and teamwork are critical in managing patients with catastrophic APS. The highest survival rate is achieved with the combination of anticoagulation, glucocorticoids, plasmapheresis, and/or IVIG. The pathophysiology of CAPS is currently unknown, but it is known that triggering factors may include cancer, infection, and surgery. The patient in this case presented with multiple DVT were managed in an integrated way. Percutaneous thrombectomy combined with anticoagulation, glucocorticoids, and IVIG were able to decrease circulating cytokines and antibodies. Early recognition